Thank you, Mr. Chairman, Chairman Rangel, Mr. Camp, members of the committee. Although healthcare spending remains a challenge for all payers, Medicare's track record has been better than that experienced by self-funded employers and commercial insurers, while offering near universal provider participation. Medicare is well positioned to take the initiative, preferably in collaboration with other public and private payers, to produce additional delivery system changes in response to current challenges. For all of the dire estimates that healthcare costs will consume the entire gross domestic product and Medicare and Medicaid the entire federal budget, in fact, we only need to reduce spending by about 1.5% per year to maintain the share of the nation's economy and the federal budget devoted to healthcare. That is achievable. Policymakers are just beginning to realize the implications of beneficiaries living longer with chronic illness, particularly multiple chronic diseases. The 20% of Medicare beneficiaries with 5 or more chronic conditions account for 2/3 of Medicare spending, see about 14 different physicians a year, and have 40 office visits. Yet Medicare and other insurance program designs, for the most part, ignore the importance of chronic illnesses in generating demands on the healthcare system and escalating healthcare costs. We have clear need for a different health professions workforce. In general, a much greater supply of primary care physicians, primary care nurse practitioners, and physician assistants, and specifically more geriatricians. Yet current physician payment policies in Medicare ignore these workforce needs and instead disproportionately reward the provision of niche specialty services such as imaging and performance of minor procedures. Whatever the blueprint for delivery system reform, it is likely to fail unless immediate steps are taken to address the likely collapse of the primary care physician workforce infrastructure in many parts of the country. There are many challenges in figuring out how to better care for patients with chronic conditions and geriatric syndromes, but this is precisely where there is the biggest bang for the buck in terms of beneficiary well-being and bending the health spending curve. Based on current work being conducted by colleagues at the Urban Institute, I would not focus as much policy attention on geographic variations in care. Our findings cast some doubt on both the magnitude of the geographic spending variations and the source of the variations that Elliott and other Dartmouth researchers have found. We will need to reconcile these different results. However, happily, policy recommendations that you've just heard Elliott present, particularly those fostering development of accountable care organizations, have merit and do not rely primarily on the geographic variations finding for their support. Our shared preferred approach to sorting out how best to serve the diverse and complex needs of patients with an array of chronic and acute care needs would be to develop and implement and improve payment models to support integrated delivery systems, which would have the size, scope, and resources to sort out themselves how best to serve the patients they care for, rather than having payers doing it from far away. It is time to move away from a one-size-fits-all payment system relying just on a Medicare fee schedule for physicians and prospective payment based on diagnosis-related groups for hospitals, but rather build on the shared savings approach used in the PGP demo to provide a payment model appropriate for these organizations. In closing, I would like to emphasize the importance of permitting individuals satisfied with their private insurance plans to stay with them in health reform. It is also important, in my opinion, to have a public plan patterned on Medicare but separate from it as an option for those seeking care. Some would restrict the ability of a public plan to control costs by altering prices and payment schedules. However, differentiating so-called price controls from all the other tools a value-based purchaser, public or private, would use is both arbitrary and unworkable, because in practice pricing services is inextricably linked to the other approaches recommended. As in Medicare, the public plan would balance spending growth restraint with the duty to preserve access to needed quality care. If the public plan moved too aggressively on cost containment, individuals would likely migrate to a private plan. Further, it would face the risk of causing hospital closures, slowing down the introduction of desirable new treatments, and for some specialties, reducing the availability of physician services. So as this debate proceeds, I think it is important to try to establish a level playing field competition between public and private plans. I think that's achievable, and I would urge the committee to give that high priority. Thank you very much.